My name is Yasmina Sisarak, and I'm your host for Healthy Brain webinar series. Today, I wanted to introduce supporting the health of people with intellectual and developmental disability by improving health literacy of caregivers webinar. The speaker, Rachel Scoss, will talk about a recent program of research focused on how people living in supported accommodation settings are supported with their health and how health literacy of caregivers influences their confidence to support health of people with intellectual disabilities in Australia. Following the research, a health literacy guide was written from the perspective of what would be useful for a caregiver to know about supporting the health of person with intellectual disability using a strength-based model of health literacy. The webinar will address how an improvement of health literacy of caregivers can improve health outcomes of people with intellectual disability. Just a couple of things before I introduce Rachel. Today's webinar is part of a Healthy Brain webinar series and is presented by the HealthMatters program. We are located at the Department of Disability and Human Development at the University of Illinois at Chicago. And the webinar series is in partnership with National Task Group on Intellectual Disabilities and Dementia Practices. And we're funded by the Centers for Disease Control and Prevention through the Healthy Brain Initiative Award. Contents of this webinar are solely the responsibility of the webinar presenters and do not represent the official views of the CDC. Now, lastly, I wanted to introduce Rachel. Let me get to my notes. Sorry about that. Rachel is a senior research fellow at the Institute for Health Research at the University of Notre Dame, Australia. Her research focuses on improving the interface between disability and mainstream health services. She works in partnership with policymakers, service providers, and consumer organizations to ensure services are more responsive to the needs of vulnerable populations. With a health literacy focus, she uses her research findings to develop resources to improve the capacity of consumers to navigate and engage with services and improve the skills of frontline practitioners to more effectively engage with consumers who may be considered vulnerable. Rachel brings lived experience as a carer of a young person with intellectual disability and has represented the carer perspective in various health, mental health, and disability advisory groups. Welcome, Rachel. One couple of last things. We do not offer CEUs for these webinars. We are recording the webinar. It will be recorded and available for you to view on YouTube with resources to download. You will be emailed within 7 days of today once the webinar is up. And then we will hold all your questions to the end. There will be about 10 to 15 minutes of question and answer section at the end of the presentation, and you can use the chat box to ask any questions. So I'm very excited, Rachel, that you're with us. I know it is 11 p.m. your time. You're near Perth, correct? In Australia.
I am in Perth. Yes.
And this is the last day of summer for you.
It is. In about an hour, it'll be officially fall.
So take it away.
But I'll say it's 31 degrees outside at the moment, and it's 11 o'clock at night.
That's Celsius.
So, that's Celsius, yes. So about 90 degrees, high 80s maybe. Anyway, thank you so much for the opportunity to present today. I'm really excited to be here. And oops, sorry, I'm doing the wrong thing. There we go. And I'd just like to first acknowledge the Whadjuk Noongar people as traditional owners of the land that I'm speaking from and pay my respects to elders past, present and emerging. And I'd also like to extend my respects to any First Nations people attending this session. So I think it's important to set the scene by telling you the perspectives that I'm bringing today. And you heard a little bit from my bio, but like many of us, I wear different hats. And the years of parenting a child with an IDD and sitting on those boards in the disability sector and the various advisory groups and committees in health, mental health and disability sectors all inform my work as a researcher. So I've had the opportunity to learn from those at the coalface, both those delivering services and those receiving services. My brand of research is very applied, and I'm generally focused on where I can add value or help build capacity so that people who might be considered vulnerable have better outcomes. Now, this handsome guy you see is my son, Andrew, and I'm mindful that as he is 15, I really need to focus on supporting him to develop the knowledge and skills to manage his own health and to make sensible choices, really just like any other parent. And it's important for me not to assume that he can't develop those skills. And at times, it has required a gentle reminder to health professionals that he needs to be included in his care. So all of these experiences have made me realise that health literacy is very important. If anything, it's made me realise how focus on health literacy can really help improve health outcomes, particularly for people with IDD. So in today's presentation, I'm going to first give an overview of health literacy. We'll consider how using a health literacy lens will highlight opportunities to make health services even more effective, particularly for vulnerable populations like those with IDD. And I'll briefly discuss a research project I recently completed, which looked at how people with disability are supported to access healthcare. This research informed the development of a health literacy guide for caregivers, and I'll spend the majority of today talking about how the guide can be used. I'm hoping to leave you with the understanding of why it's important that we focus on health literacy for caregivers. Health systems are fragmented. Many people struggle to find their way to the right service at the right time, and when they are there, engage effectively. Following the interaction, we want people to then know what they need to do to manage their condition. For people with IDD, they may need additional support to do this, and this is where the role of the caregiver is so important. Health literacy skills are critical to effective navigation and engagement, as well as ongoing management of chronic conditions. So health literacy was once thought of as a person's ability to read the pill bottle and take the medication as directed. That's a little bit facetious, I guess, but the concept of health literacy has evolved over the years. The Australian Institute of Health and Welfare states that health literacy relates to how people access, understand, and use health information in ways that benefit their health. I use a definition of health literacy developed by Richard Osborne and colleagues at Swinburne University. We need to think about the characteristics and supports a person needs to engage to make decisions and to manage their health. This broader model of health literacy allows us to consider a person's beliefs, their motivation, and their confidence to engage with their health. It's a strength-based approach that considers the needs of the community, and I think we saw a range of examples of the importance of this with the recent pandemic. Of course, we're all different. We have different strengths and weaknesses, but models of care may not be sufficiently flexible, and we may inadvertently create barriers to access or engagement. Health literacy will impact how people use and engage with services. There are many points on a healthcare journey where potential barriers lie in wait for people. When we look at the problems with a health literacy filter, we can easily see ways to overcome or reduce those barriers. I think it's also important to think of health in a holistic way, from health promotion and preventative care through to management of chronic or acute health conditions. And this is where my research is focused with respect to the needs of people with IDD, their caregivers, and the health professionals. I've been using health literacy instruments developed by Richard Osborne and his group. In my most recent study, I used the health literacy questionnaire, which you see at the top, and it has 9 dimensions that you can see here. Rather than a total health literacy score, I can perform cluster analysis and identify different health literacy profiles across those domains. So I can look at the differences between people. And from there, a needs analysis will give me more insight into the optimal approach to improving health literacy for each of those profiles. And I've just included another couple of instruments there in case you're interested. For example, if you're working in digital health space, the electronic health literacy questionnaire has different dimensions, including confidence in, trust of, and access to digital services. If you're considering how a person manages their health and engages with services, for example, when transitioning from paediatric to adult services, I would use the Health Education Impact Questionnaire. And so that's the end of my brief overview of health literacy. And hopefully I'm not going too fast, and hopefully you can understand me through my accent. So much of the evidence about IDD and health is focused on the hospital experience using large administrative data sets. Hospitals are obviously an important component of health systems, but it's not the only part of the health system. And people may need to use multiple services in the community. They may need to receive services from more than one health service, go to multiple allied health practitioners, need dental and mental health services, and go to more than one GP clinic. And because I was interested in the health of people with IDD, I also recognised that we need to focus on how they are supported to access those health services, and in part consider what the general health literacy is in the disability sector. So the research focused on how health of people with disability is managed within the supported accommodation settings or the group homes. In general, this group of people have significant functional impairment due to their disability to be even eligible for the funding that's required for this via Australia's National Disability Insurance Scheme. And I just want to give a plug to say I'm grateful to the Western Australian Department of Health who funded the work through a research translation project grant. So I just want to give you a quick overview of the three components of the project. First, I did an observational case study with a large organisation who provides supported accommodation to 160 clients with data collected over an 18-month period. I worked with the organisation to develop a process to capture relevant information about each health service event that their clients attended. And I had general questions about health service utilisation with health services defined broadly, including primary health, allied health, dental and mental health services in the community, together with hospital service use, including outpatients, emergency, or when they are actually admitted to hospital. I was interested in how the person was supported to access the services with a focus on staffing and transport. For example, I wanted to know whether a staff member attended the service with the individual, and if so, what was their role and whether there was any impact on other staff or other individuals in the group home. I collected data on whether there were additional staff hours via backfill or overtime, and whether there was a need to contact a medical guardian. Given that health appointments often don't happen in isolation, I was also interested in understanding more about follow-up and the quality of health information exchange. The second part focused on health literacy of the direct care workforce, and I worked with 4 different disability organisations for this part. When thinking about how people with disability are supported to access healthcare, I thought that the direct care workers' health literacy was a critical component to the quality of that support. So I used the health literacy questionnaire that I showed you earlier, and we identified 7 different health literacy profiles using the cluster analysis, grouping the workers together depending on their strengths and their gaps across the health literacy domains. These health literacy profiles are important if we want to develop training for this workforce so that we can target the information for their needs. I was also interested in knowing how confident the workers were in supporting the health of their clients. These health behaviour self-efficacy items asked how confident the person was in undertaking specific behaviours, such as helping someone stick to an exercise or diet routine, observing changes in health or mood, understanding signs and symptoms that someone is unwell, communicating about someone's health, helping someone find health information, and various other behaviours to support health promotion. The final part of the study was a series of qualitative interviews, giving me the opportunity to chat to a range of different people about their perspectives. So I talked to disability service executives, including CEOs, managers and clinical managers across 9 organisations. I spoke to family caregivers and adults with IDD. I also managed to interview a handful of GPs or general practitioners. So I'm not going to go into the research findings in any detail here, but I am happy to be to follow up with you later if you're interested. And I promise that I am working at getting the papers published. But in general, the research highlighted that there are significant opportunities to improve the health of people with disability if we focus on the health literacy of the direct care workforce or caregivers more broadly. The original intention of the grant was to develop and evaluate a health literacy intervention in disability sector organisations. However, my timing was really lousy. Thanks to COVID lockdown, there was no opportunity to deliver any intervention, but it did give me more time to focus on developing the guide to supporting healthcare. So this is the guide you see here. It's aimed at caregivers of people with IDD or cognitive impairment. The guide is structured to take the caregiver through different aspects of supporting the health of a person with IDD, as well as how they can support the person to build their own health literacy skills so that they may participate more fully in their health journey. If you think back to the model of health literacy I showed you earlier, you'll notice that the guide aligns with many of the health literacy domains. Essentially, the guide borrows heavily from an array of excellent work that's gone on from all over the world, bringing it together into the one resource. There was a need for some of the resources to be tweaked for Australian conditions. For example, legislation related to decision-making differs by jurisdiction, and the best examples I found were from Canada and the UK. And obviously, I focused on the Australian health system, but I am in discussions to adapt the guide for other contexts, following requests from people in New Zealand and Germany. The guide is freely available at the website you see here, so please feel free to download it and pass it around to whomever you think it might be useful for. I provide a free high-resolution version for anyone who wants to do print runs, and several local organisations have taken up that offer and provided it to all their support staff. Since the guide's launch last October, it is being used in a number of disability service organisations who provide supported accommodation and is being included as a training resource for a variety of health professionals. So I thought it might be helpful to go through the guide in a little more detail, highlighting how the guide was informed by the research findings and focusing on ideas to consider which may help to improve the health of a person with IDD. First of all, health promotion messages rarely target people with IDD. While there is potential for direct care workers to translate the messages into their work practice, our findings showed that the confidence to do that was linked to their personal health literacy, particularly with respect to describing the benefit of healthy habits, finding appropriate health promotion resources, and helping someone stick to a diet and exercise routine. Many of those surveyed had relative weaknesses in their ability to know whether information was true or important. It was clear that there would need to be targeted information for direct care workers, bringing all the credible health promotion information together. So the first section on healthy lifestyle provides information about healthy diet, exercise and activity levels, healthy weight, sleep, alcohol and other drugs, mental well-being, and healthy skin. And with respect to well-being, I included information about how caregivers can support spiritual beliefs and cultural practices, help the person develop healthy relationships, develop cyber safety practices, and prevent sexual abuse or exploitation. So you can see I have a very broad view of what holistic healthcare means. Each topic provides general information for the caregiver and where they can go to find further information, as well as what they might like to consider with respect to supporting the health and well-being of the person with IDD. Where it exists, I point people to accessible information for a person with IDD in the form of an easy-read document. On that note, later in the guide, there is detail on where to find easy-read libraries and information on creating easy-read resources if that's required. Our research highlighted that healthy living goals were not necessarily included in people's care plans, as the care plans tend to focus on the day-to-day management of chronic or acute health conditions. For people living in supported accommodation, There is opportunity for the organisations to drive health promotion activities through their policies and through staff development. It takes a culture of thinking how health can be improved by modifying lifestyle factors, rather than acceptance of the status quo. And I would like to see organisations having clinical governance frameworks that benchmark health promotion and preventative care strategies. Disability sector organisations need staff with the skills to engage with the person with IDD, to enable them to set personal goals for healthy living, and then knowing how to support the person to make those lifestyle changes. Within the organisations I was working with, there was a lot of interest in upskilling the workforce and having health and wellbeing champions. So I use every opportunity I can to promote the HealthMatters curriculum to support this. Our research highlighted that within the disability sector, opportunities for preventative care are not well understood, and there was a general agreement that more could be done. While there are population-level preventative care campaigns, such as screening for cancers and vaccination drives, people with IDD may not necessarily access them. Interestingly, with respect to the case study organisation, I did observe the Hawthorn effect as their vaccination rates increased over the 18 months, in part because of COVID, but also in part because I was providing quarterly feedback to the organisation, and there was a benefit to them for having an overview of service utilisation and looking at trends over time, rather than just the day-to-day responding to health issues. I would argue that a focus on preventative care can be cost-effective, as it can generally be planned for, which is important when thinking about staffing and transport logistics. In our case study, the cost to the organisation of providing support to their clients to access the healthcare was not insubstantial, and neither were the logistics. If you consider the juggling that you have to do to help a member of your family access healthcare, just think then what the logistics are if you need to organise the healthcare for 160 people to provide the support for them to access the care they need in a timely manner. So the ability to plan for preventative care is beneficial to how the organisation runs. In general, there is a need for practice guidelines for disability organisations to prioritise access to preventative health care. For direct care workers to support access to these services, they must understand the importance of them. So the guide contains an overview of the common population campaigns. Poor oral health was a recurring theme from my interviews, with insufficient focus on preventative oral care in care plans. Excuse me. Consequently, I included dental care as it is an area of health that often gets overlooked, but can be improved. In the guide, there is a link to an oral health training program for direct care workers developed by dentists in Ireland, which is currently being evaluated. And we must not overlook the importance of the person with IDD developing their own health literacy skills for preventative health care. I'll touch on this again later, but it's important to note that many people with IDD are not given the opportunity to learn these skills as they progress through school or during adulthood. And on a personal note, as I was pulling the guide together, I realised that there was just so much more that I should be doing to support my 15-year-old son to make decisions, communicate about his health, and engage with health professionals, amongst the other things you do with teenagers. So planning for optimal health is important for this group of people. The health literate caregiver is well placed to support the person with IDD to engage with the planning process and help them be central to the decision making about their healthcare and their health journey. People with IDD often have a range of comorbid health or mental health conditions that also need to be managed. From our survey, we found that direct care workers were not always confident they knew what to do. Organisations need to have robust processes to support the staff. However, the guide provides information regarding many of the common chronic health conditions and where caregivers can find more information about them. Our research highlighted the importance of strengthening the connection of the person with IDD and their primary care practitioner or GP. There are practical reasons why there should be enhanced engagement with primary care health professionals. Where possible, organisations tried to form relationships with clinics to improve continuity of care and understanding of the client's health needs. Ideally, there is potential for in-home visits, which is particularly beneficial for people who might experience anxiety or challenging behaviours in external environments. Direct care workers have a critical role in supporting the management of chronic health conditions. As much as possible, the person with IDD needs to be empowered to understand the condition, and the caregiver has an ongoing role in facilitating this. They may also need to facilitate support so that the condition does not make the person with disability even more socially isolated. Amongst other key skills useful for supporting chronic health conditions, caregivers need to support communication with health professionals, or at times communicate on the individual's behalf. And they also need to be able to effectively communicate about follow-up requirements such as medication changes or referrals following any health service event. From our case study, we learnt that a staff member attended the health appointment almost always with the individual, and that for primary care visits, follow-up was required in 83% of the visits. In the context of supported accommodation, any request for follow-up needs to be actioned by somebody. Care plans need to be updated. Support staff may need to be informed of the changed care needs or medication regimes. Appointments need to be made with the logistics worked out regarding how the person will get there, get to where they need to be, and who will support them to get there. So the ability to actively engage with healthcare providers is another skill for the caregiver accompanying the person with IDD to health appointments. It's important for the disability organisations to have processes in place to support health information exchange. When you're providing this level of support for 160 people, that is not a trivial matter. We've also found that the confidence to support the health of people with IDD is related to the individual health literacy. However, with respect to building the health literacy capacity of caregivers, we were unable to find relevant training. In Australia, funding is available for training in a narrow range of topics associated with specific disability-related health supports. So, for example, direct care workers can access training about mealtime management for a person who is PEG-fed or who has dysphagia. Our research found that health literacy training needs to be delivered in a way that's cost-effective to the organisations and can be immediately translated to work practice. A hybrid model of training is required, combining train-the-trainer approaches with short digital learning modules and relevant resources for the direct care workers to use and practice with the clients that they support. And I've provided links to useful resources that can be used in congregate settings where I could find them. And we're in the process of developing more resources to fill the identified gaps. Many people with IDD may also experience mental health problems, and unfortunately, many of the symptoms are attributed to their disability rather than being seen as a sign that something else is going on. As the person with IDD may not be able to describe their feelings or communicate what they need, they may use behaviour to communicate their distress. Caregivers need to understand how behaviour can be a form of communication and be alert to any changes in behaviour. Often, they'll need to initiate connection to the appropriate health professional and provide the relevant information about the signs and symptoms that they've observed. The observant caregiver can notice something is going on from soft signs before any biological changes can be measured. Our research provided examples of people with IDD experiencing pain, yet behavioural changes were dismissed as just being naughty, and times where the caregiver had to advocate to the health professional that the person with IDD was experiencing pain. While the signs of pain are often specific to the individual, it's critical that caregivers can recognise them. Observing changes in health or initiating action may be time critical in some situations, so it's important that caregivers are competent to do so. Potentially, there's also a need for the caregiver to communicate about the change in health status, particularly for people who may have difficulty communicating. From the case study, I learnt that direct care workers were predominantly the source of verbal information for the health professional, providing information 57 to 83% of the time, depending on the type of service. However, from our qualitative study, we heard that direct care workers often didn't know what to look for or how to measure and communicate about vital signs which were important for clinical decision making. Some did not have confidence to communicate with the health professional on their client's behalf. This highlights that processes within disability organisations must be explicit about the direct care worker role, and clear guidance is needed about monitoring health and what to do if someone is becoming unwell. I tried to address these challenges in the guide by detailing different signs and observations that the caregiver can consider and how to initiate help seeking when required. Another theme that emerged from the qualitative research was the role of the direct caregiver when the person with IDD was dying or when someone close to them was dying. Many of us don't have much personal experience with the process of dying, and it can be a difficult time for everyone involved. We heard about situations where the direct care workers were essentially undertaking palliative care duties as health professionals weren't confident in supporting the person with IDD. We heard about times when a person with IDD was not told that they were in palliative care. And we also heard about times when the person with IDD had been blindsided by not being told that someone close to them was dying, and that following the bereavement, caregivers felt ill-equipped to support them with their loss. I felt it was important to include information about death and dying in the guide so that caregivers feel more capable of providing support throughout. If you remember the potential barriers for effective engagement from the earlier slide, you'll see there's quite a bit we can do to support people with IDD to engage with health professionals. This could be as simple as helping the person to choose a doctor that they are comfortable with, or helping them understand what they can do before, during, and after their appointment. The caregiver is often well placed to find accessible information for the person, and that can also support their decision making. Unfortunately, health services are sometimes provided within the deficit model of disability, the medical model, and there can be a need for the caregiver to be advocating for person-centred care as well as for the appropriate level of care to be delivered. This is more likely when there is not an established relationship between the health professional and the person with IDD. We heard about the importance of the caregiver in modelling effective communication with the person with IDD and demonstrating how to support them to make decisions for themselves. Now moving on to the hospitals, the caregiver role in hospital settings is varied, and it's really important to clarify what is and what is not expected. The guide outlines different ways a caregiver can support the person with IDD throughout the hospital journey. In a support role, the caregiver may need to provide information about a person's health status together with other health information and advocate on behalf of the person. They will likely need to let health staff know about the person's support needs and potentially behavioural support strategies. This can often be ongoing, needing to be repeated at every transition point, for example, on shift change, ward change, or going for a procedure like an X-ray. For planned admissions, there is opportunity for caregivers to influence the processes, particularly if it has the potential to cause distress or poor outcomes. The caregiver may also have a role in supporting the person with IDD to provide informed consent, or ensuring that if a medical guardianship is in place, that the guardian can provide consent. There are many easy-read resources available to help the person with IDD understand what is going to happen and what they need to do. And so, again, the role of the caregiver is to help the person understand this as much as is possible so that they can be central to the decision-making about their care. So now we come to how caregivers can support the person with IDD to develop their health literacy skills and knowledge and to support their rights. In many instances, we heard that people were not aware of different tools they could use to support the person with IDD or of the caregiver role in supporting communication. In places, the tools have been used very effectively, but they weren't being used in a widespread manner. At times, there were different perspectives. For example, how care plans can be used and what can be included in them. And the guide is aimed to raise awareness of what's available to support communication about health and links to other useful examples. Making decisions about your health is a fundamental right, yet many people with IDD are not supported to do so. And as I mentioned before, haven't been given the opportunity to develop the skills to do so. Decision making is a multi-step process, and as a supporter, we can break down the process and support decision making in many ways, depending on the person's needs. For example, caregivers may need to provide support to the person to access relevant information about their choices. They may need to provide advice. Their role could be related to logistics and scheduling. And as I mentioned before, they could also have a role in ensuring the person has enough time to think about it and talk about what they want their choice to be, and then helping the person communicate their decision. I think it's also important for caregivers to know about dignity of risk. In short, it means that we all have the right to make choices and take risks. It does mean we can make unwise choices, and I've certainly got a fair few of those, but it is our right to do so. Without getting too deep into the weeds regarding disability studies, at times there is a need to highlight dignity of risk if caregivers have a belief system that people with IDD can't or shouldn't make decisions. I believe that caregivers should focus on providing accessible information so the person with IDD can make an informed decision. Different governments have different rules around consent, so it is important to check the local legislation regarding informed consent and whether someone has the capacity to provide it. It's important for caregivers to know that sometimes people may need help with decision making in some aspects of their life, but not in others. Decision aids can help explore the supports required in those different domains, and many people with IDD can be supported to communicate their wishes. I should add that in my jurisdiction, the legislation states that decisions should be made in the best interests of the person, but the more contemporary view from other jurisdictions is that decisions are made according to the person's wishes. I included goal setting as an important skill for people with IDD to learn, as it's a way to provide more personal agency in their lives. Quite likely, we all have health behaviours we could set goals around, and people with IDD are no different. Caregivers have an important role in helping the person decide what they would like to change in their life and then make the SMART goal and action plan. They then have a role in helping the person to achieve that goal. The guide highlights a range of resources which can assist the caregiver to support goal setting and then implement the activities required to achieve those goals. At times, accessing health services might not go as smoothly as we'd like. Long waiting times, chaotic environments, sensory overload, and past traumatic experiences can all make receiving care difficult. The caregiver has a role in supporting the person with IDD in a way that reduces the angst. When there is opportunity to plan, having social stories or easy reads can help the person know what to expect, and that can be one way to help reduce anxiety. At times, there might be a need to think about what will happen in various circumstances along all of the processes and what we might be able to do to minimise the distress or the anxiety. In essence, this is having a safety plan in place and knowing what will be helpful for the person with IDD to enable them to cope with the situation. Unfortunately, traumatic experiences can occur. Themes from the qualitative research highlighted the need for trauma-informed care and the role of the caregiver in facilitating that for the person with IDD. However, the caregiver can also experience trauma through their role, so the guide also details what they can do themselves to help themselves recover. If a situation is likely to be repeated, then desensitisation can be an effective approach to reduce ongoing trauma and harm. And while it's not expected that a caregiver will provide the desensitisation, it is useful for them to know about and to seek appropriate support for the person with IDD. And I just wanted to touch on information as being able to appraise information and knowing what to do with it were two of those health literacy domains in the model that I showed you earlier. So I included a section in the guide about finding trustworthy information. As we know, there is an overload of information online, and we've seen in recent years that it is not all necessarily true. And I believe that caregivers have a role in helping a person with IDD to find credible information and making sure that they can access information that is reliable. Another domain of health literacy is being able to navigate to the right health supports. So I believe that caregivers need to have a reasonable understanding of the health system where they live. It is worthwhile for caregivers to know about patient rights and what to do if things go wrong, as they will be supporting the person with IDD on a healthcare journey. Similarly, they need to have a basic understanding of how services fit together in their part of the world and how health care is paid for. These details are all specific to the jurisdiction, so I'm not going to take up your time telling you about the Australian system, which is detailed in the guide. However, as I mentioned earlier, I'm very happy to work with groups to adapt this section to their context. The healthcare team is also made up of a range of different health professionals. At times, there is overlap of expertise, and it's helpful for caregivers to have a basic understanding of who does what so that they can help the person with IDD navigate to the right health professional. So now we come to the appendices. There was information that came up through the interviews that warranted inclusion in an appendix. The Brightwater Healthy Living Checklist is a great start if a caregiver is supporting a person with IDD to consider what they want to change in their lives, which could be prior to a goal-setting exercise. It also doubles as a useful checklist to do before going to a doctor for an annual health check or for any planning processes like we have to do for our National Disability Insurance Scheme or the similar. People with IDD may be prescribed psychotropic medication, and this was discussed by a number of stakeholders in my interviews. The medication pathway comes from a program in the UK called STOMP, which stands for Stopping Over-Medication of People with a Learning Disability, Autism, or both with psychotropic medications, which is a bit of a mouthful. It's a very useful framework for caregivers to talk with the health professional when these medications are being discussed. Obviously, the role of the paid direct care worker is different from the family caregiver, who may also have a guardianship role. However, many of the questions are relevant to both types of caregiver, particularly with respect to questions to ask once a decision for medication has been made. The NEWS2 system is a simple aggregate scoring system that can be used for people living in congregate settings. In essence, physiological observations are assigned a score reflecting on how they vary from normal. The score then provides a systematic indication of how urgent care is required. Interestingly, the NEWS2 system had a good uptake in the UK for use in residential aged care settings at the height of COVID. The legal framework for decision making was included, as many stakeholders highlighted that it can be really confusing. In both the case study and interviews with disability executives, the requirement to seek consent from the medical guardian was not insignificant. For example, occurring for half of the health service visits in the case study, with a decision required about a third of those times. Guardianship could also be problematic, particularly when assigned by the State Administrative Tribunal via our Guardianship and Administration Act, and it really required caregivers to understand what their role was in those instances. Health passports were often mentioned as a useful tool, particularly if a person with IDD is interacting regularly with hospitals. And there are a variety of different examples around, so I just provided all the links together. So in conclusion, I hope the guide provides caregivers with some useful ideas that they can consider as they support the health of a person with IDD. As we all have different strengths and different needs, it isn't prescriptive. Rather, it's a resource that can be dipped into as the need arises. If you have any resources that could be included in the next edition, please do let me know about them. I hope to update the guide periodically as useful resources become available. Similarly, if you think there's a need for an additional section that it would be useful, then I would welcome your suggestions. My next steps are to continue to develop a variety of resources that are helpful for various stakeholders at the health and disability interface. I'd welcome any suggestions you have for funding this work, as trying to write it into research grant applications is not as much fun as it sounds. And I'd also welcome opportunities to collaborate with you if I can be helpful. So finally, I'd just like to thank you all for attending today. And again, my thanks to Jasmina and Beth for the opportunity to present. And I think we're going to open it up for questions and comments now. Thanks very much.
Thank you so much, Rachel, for your presentation. As you were speaking, I was putting all of the resources that I could find in the chat box. Specifically, your health literacy guide is available and it can be downloaded. And I put it in the links. We will gather all of these resources and put them on our YouTube channel as well, with the PowerPoint deck and the recording. So you don't have to be scrambling to take these down at this point. You will be emailed once we put that up. At this point, we are opening for questions. Please let me know if there are any questions. One of the questions that Beth and I had, we would like to know, with your work, what has been the most surprising to you while you were developing the guide?
Personally, it was most surprising that I wasn't doing a bunch of things that I really needed to be doing for my own child, because I hadn't thought of how to connect him in to things like annual health checks and start thinking of my way through about how do we develop those skills, so that he's in charge of it. In charge of it, and it took a little bit of a step back from me. But I think the main thing that's been really surprising, I suppose, is just how organisations have grabbed hold of this resource to use. Over here, there isn't health literacy training in the certificates that the workforce usually have prior to going into the job. And so a lot of the training was being developed, by buddy system, which means it's going to be a little bit inconsistent because it's only going to be as good as your buddy. And so I think just having a consistent source of information and being able for them to easily find the credible sources of information. So I'll say all of the information I found were from what I would call trusted health sites. So it was all credible. They just found that a lot easier so that they could reduce the amount of disinformation that goes around. There's often sort of dodgy quack solutions to things in the disability sector, and so it was really important for me to make sure people were actually accessing credible information.
And then in follow-up, you mentioned your son. I wonder what feels or seems most urgent to you as a mom and as a researcher in regards to health literacy for people with intellectual disability and their support persons. I know it's a loaded question.
Well, what is critical for me? So I will say that for a lot of his schooling, he was not actually accessing educational content around health at all. It was deemed a bit too hard. And I used to joke that he has coloured in enough body parts, and that was pretty much all that he was getting until last year. But I think what I would really like to see is a curriculum that can span high school years and also adulthood, assuming that we can have lifelong learning, and so that people can continue to develop those skills no matter what starting point they're coming from. And I think it's very challenging in education, in mainstream education in particular, to be providing access to the curriculum at a particular point in time, because what he needs is quite different from other people of his age who don't have an intellectual disability. So I guess my major priority, and certainly trying to progress it, is to develop a health literacy curriculum that could span and teach those skills. So over here, we've certainly had a number of projects that I'm aware of, which is focused on empowerment and personal agency, but they don't necessarily go further into other skills that I mentioned, like goal setting and decision making and things like that, which I think are probably more important with respect to health.
In your research, did you make, oh, go ahead, sorry.
I was just going to say, hopefully that answered your question.
Thank you, yes. In your research, did you make use of any family reported outcomes questionnaire like the From 16?
No, but I would like to follow that up. We have a project that got funded recently, which is focusing on children and young people with IDD, and there will be a focus on that, particularly the transition from paediatric to adult services, which is where a lot of young people fall into a hole with respect to their health. So we'll follow up with you about that that instrument and consider using it, that's for sure. But that will focus really on, family report, and also we're hoping to establish young person report around their health as well. Hopefully ending up in a co-design process. So
the on the same sort of spectrum on the other side, do you have any resources on how to support an individual with intellectual disability and dementia?
So that is a section that has already been suggested for the next edition of the guide. And I think, in particular too, because there are certainly some syndromes where they are more predisposed to dementia, like Down syndrome. There is a lot of interest in developing something. So very happy to put that one on the agenda. Maybe we could collaborate.
We would be happy to. And I was looking at your guide, and I was actually looking at the table of contents, and everything is really relevant to the U.S. system, except the understanding the health system that could be amended to reflect the United States system, and we'll talk offline about that. Another question, more of as a comment, as a pharmacist doing medication reviews for residents of group homes, I find health numeracy to be a large problem for caregivers. For example, interpreting a prescription label for a liquid and determining how much of a dose to give.
Yeah, I completely agree with you. Within the organisations that I work with, they have I'd say fairly rigorous processes around the giving of medications, because anything that is not given as anticipated or as required is actually a reportable incident. So they're very keen to not have those. But I would also say that I think it's about 20% of the adults with intellectual disability live in congregate settings, and the rest are living out in the community. And so there is a huge challenge with making sure people are getting the appropriate medications. I think things like Webster packs have certainly improved. Don't know if you have them in the US, but that's where the pharmacist will package up the dosages and the times of day and each of the days of the week. So that has really helped people take the medication, and certainly helped people understand if they haven't taken medication correctly. But I'd say another area of concern is knowing what to do if medication hasn't been taken appropriately. So, whether or not you take the 2 doses at next time or so on, because of the challenges with so much difference between, each medication. So I always advocate that people should make friends with their local pharmacist, because they should be seen as an integral person in that person's care team, and make use of their wisdom and knowledge. I think the medication reviews are critically important for this group. Certainly in what I heard from one GP who was doing medication reviews was, you know, horror stories about how someone had been on some medications for decades without it being indicated. No one really knew whether or not he, you know, for this gentleman, whether he had seizures or not, but he was on anti-seizure type medications. So it can be really problematic, and a lot of people see it very much as set and forget rather than ongoing review. So I've been trying to preach that medication reviews are necessary as part of that care plan, and it's something that has to be planned for by the organisation. At the moment, oftentimes it's initiated by a family member. Hope that covers that.
Yes, I think we can talk about overprescribing and medication for an entire hour. Another question, you mentioned oral health challenges. Can you speak about challenges or solutions with access delivery to dental care? Any trainings for dental professionals in the health literacy field?
So there is a little bit of work beginning to happen about that here. We have a national roadmap for improving the health of people with intellectual disability, and dental care has been on the agenda for that. Part of the challenge for us over here, at least, is that we have a limited number of specialist dentists who provide that work. I've certainly, from my own personal point of view, we found a dentist very early on, and we've slowly been developing the tolerance to be able to cope with typical dental procedures in the chair. And, you know, there are certainly things that we can do to help some people with IDD improve the way they can brush their teeth and make be more aware of their oral health, you know, making more choices about whether you're having fizzy drinks or sodas or whether you're going to drink water and things like that. So there's a lot of those preventative care type things that we can do. When it comes to the health, the dentists themselves, it's been a little bit tricky because, like any crowded curriculum that they have in pre-service training, they often will say, you know, what would you have us take out? I would argue that, you know, with a certain proportion of the population having an intellectual disability or cognitive impairment or dementia, it's something that they should be seeing as a group that they should be treating anyway. So I think there's an ongoing conversation with dental associations and so on. For many parents that I've spoken to, many of them think that the only option is to use a general anaesthetic and get everything done at the one time. There are some preventative measures that can occur if that's the case, with the sealant on the molars as an example, which can reduce the cavities. But I think beyond thinking that we just go straight for a general anaesthetic, which has its own risks, there is a lot that we could do earlier on in the journey about preventative care, and just slowly improve people's oral health through the variety of things. So the dental program that I mentioned from Ireland, it was a training program for direct care workers, and it has a range of different supports, from, you know, how to brush a person's teeth safely through to how to support them to develop brushing technique and things like that. And I think it's brushmyteeth.ie is where you can go to the website, and they do have papers out on their program, so you can follow up with that.
Thanks, Rachel. All right, we are at the hour. I just wanted to get this brush my teeth to everyone. Thanks, Judy. Judy said the American Academy of Developmental Medicine and Dentistry has recently been offering several webinars related to training for oral health professionals. Judy, if you have the link, or I'll just take a look and I'll make sure we post it in any references or resources on our YouTube channel. Rachel, thank you so much for this amazing webinar. We will keep everyone posted on additional updates and developments, and I hope that we can actually collaborate on some of the pieces of your health literacy tool. One other thing to mention that Beth actually reminded me of is that we will be posting soon over medication in older adults with intellectual disability, risks for brain health. It is a statement jointly released through with the National Task Group on Intellectual Disabilities and Dementia Practices and the HealthMatters program. We will also include the link to the document on the resources. This is part of an advisory series on risk reduction in adults with intellectual disability and promoting healthy brain outcomes. So we will include that resource as well. Thank you so much again. Thank you all for attending. I'm going to post a link to our additional webinars, and the next one is actually this Wednesday. That's going to be I'm just posting the link. It is on brain health and trauma among people with intellectual and developmental disability, systemic bias and ableism in healthcare. It is a 4-part series from March through April. I just posted a link so you can take a look. Thank you again. Rachel, thank you so much. I hope you get some sleep, and we will chat soon.
Thank you very much.
Good night, and have a great day, the rest of you. Thank you so much.
Thank you.
Thank you.
Bye, everyone.
Nice to see you.
Bye.
Bye-bye. Oh, nice to see Lisa.